From the JAMA Network, this is JAMA Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Surgery.
Hello and welcome to our listeners around the world. This is the JAMA Surgery Podcast, and I am your host, Dr. Amalia Cochran. Our topic today is the long-term outcomes of a clinical trial comparing sleeve gastrectomy and Roux-en-Y gastric bypass based upon the Swiss multicenter bypass or sleeve study, which you will hear us refer to as SMBOSS today. A quick definition for our listeners with BPD-DS, which you will hear referred to throughout this podcast. That is biliopancreatic diversion with duodenal switch. I have the pleasure of speaking with Dr. Marko Kraljević.
Hello.
And Dr. Ralph Peterli.
Hello.
They are coming to us today from the Department of Visceral Surgery at the University Digestive Healthcare Center, or Kraljević, in Basel, Switzerland. Welcome to you both. The work that is presented in this particular manuscript is a longer-term follow-up of prior work that you all did describing medium-term outcomes following metabolic surgery, and more specifically comparing Roux-en-Y gastric bypass with gastric sleeve. Will you please provide us with a brief introduction to the previous findings from the SMBOSS study, and then can you explain to our listeners why it was important to expand further upon that work?
Well, thank you very much for the invitation and the privilege to be talking about the SMBOSS trial. Well, we did actually publish the early results where we could show that sleeve could be performed faster. I mean, this is not such a surprise, with a tendency to be a safer operation with less morbidity, but that was not significant. At 3 years, we saw no significant difference in weight loss, equal rate of vitamin deficiency, which was a surprise, but more pronounced so after bypass. And then in the 5-year results, with a follow-up rate of 95%, we saw a 7.2% better excess BMI loss after bypass compared to sleeve. But after adjustment for multiple comparisons, this difference did not reach significance. But we did see in comorbidity remission rates similar results except for dyslipidemia and GERD being reflux that was better treated with bypass. And also with patients that did not suffer from GERD at baseline developed GERD in 32% of the cases. And we did not see a difference in complications. But as it is in many bariatric operations, they show good midterm results, but in the long run, after 10 years and more, durability and side effect issues become more important, as we have seen in our own cohorts of, for instance, BPD-DS, so gastric bands. The BPD-DS had an excellent weight loss result, but high number of side effects and reoperations. So that was the reason to expand to a longer follow-up in the SMBOSS trial.
As I read the methods section and then delved further into the results, I was particularly impressed by the care that you all took by including information on the per-protocol analysis for each study period as part of this work. That's not something that I necessarily remember seeing before in a longitudinal study like this. So I wanted to hear more about why did you all think that that was important?
The intention to treat analysis reflects the real-world effectiveness of a treatment because it includes all participants who were randomized, regardless of whether they followed the assigned protocol or not. On the other hand, the per-protocol analysis focuses on participants who were strictly adhered to their initial operation, which was sleeve gastrectomy or Roux-en-Y gastric bypass, giving an idea of the surgery's potential benefit under ideal conditions. However, one limitation of the per-protocol analysis is that it may overestimate the treatment's effectiveness because it excludes those who didn't adhere to the initial operation, making it less reflective of real-world scenarios. The aim of our study was to understand both real-world outcomes and the specific long-term effects of each operation in the long run.
Were there any findings from the long-term follow-up that were particularly surprising to either of you?
Well, this long-term follow-up study of the SMBOSS trial revealed definitely some surprising findings. The figure with the Kaplan-Meier survival curve tracks the time to conversion over the study period, shows a significant increase in conversions for sleeve gastrectomy patients after 5 years. Conversion rates for sleeve rose from 13% up to 30%, while only 6% of the Roux-en-Y gastric bypass patients required a revision after 10 years. However, the fact that many sleeve gastrectomy patients needed a conversion to a different anatomy supports the original concept of the procedure as a safe first step in treating obesity.
But may I jump in here and just add to that if we estimate that 300,000 primary bariatric procedures per year are performed in the US, and 2/3 of them being sleeve gastrectomies, there will be a large number of patients potentially needing a conversion operation in the future. So this is actually what was important for us to demonstrate, that sleeve is a potent operation, but is linked to a high rate of conversions over time.
You mentioned this specifically in the context of how many metabolic surgeries are conducted in the United States, which I think is a very interesting point, because there's a trend that we are seeing, something that does not occur in the Swiss healthcare system, because we rely on private insurers here so much that many of them are putting a lifetime cap on treatments around metabolic surgery. And so I could see that that could be something that in the American context becomes particularly troublesome for us. With a clinical trial like this, I'm always incredibly curious about the impact on clinical care. And so I wanted to hear if the results from the SM-BOSS study have changed your recommendations for patients undergoing metabolic surgery prior to finding these results, or if they're going to change now.
Well, it actually has. As in most European countries, but especially in Switzerland, we are conservative. We always perform more bypasses than sleeves. With similar results from our own sleeve cohort outside the RCT, with a high conversion rate over time, we perform less sleeves than in the past. So the proportion of primary bariatric procedures, sleeves, has dropped from about 35% to approximately 10%. So all others are being bypass procedures of what kind whatsoever. The recently published OSBAC trial from Norway, with a 5-year remission rates comparing sleeve and bypass that were twice as high after bypass, underlines this observation that we have the impression that bypass as a standalone procedure has a higher potential. So in clinical practice, if there is no contraindication for either sleeve or bypass, the patient can choose, after extensive information of pros and cons in the early setting, but also in terms of long-term complications, and then the patient can choose what he or she prefers.
Clearly, this is work that does have clinical impact from what you are describing, and it certainly sounds like it has dramatically changed practices over time within Switzerland, and that to some degree these long-term outcomes help to reinforce things that you all felt that you were seeing clinically. I actually want to go all the way back to when you all started the SM-BOSS study, because I can't help but wonder what made you think to look at this question in the first place.
Well, I had experience with BPDDS, so I knew about sleeve gastrectomy as a part of that hypoabsorptive procedure. And I was confronted with the concept of sleeve gastrectomy as a standalone procedure. And I was a bit skeptical, but that's why we designed this trial as a comparative trial, because at the time we just did not know the potential of a rather narrow sleeve as a standalone procedure comparing to the standard Roux-en-Y gastric bypass. And we were just really open to it. And if we compare that to the almost at the same time performed Finnish trial, the sleeve pass trial, they had the concept of an equivalence trial. And there they had to define pre-specified margin of what was equivalent. They also had almost 8% difference in excess BMI loss, but because of their trial design, it did not reach significance. So we merged our two studies, and then we could show that sleeve was not as good in terms of weight loss and comorbidity remission as bypass. So, I mean, we are happy we have a sleeve as an alternative to a bypass, but we still believe that bypass is just stronger. But it's good to have both.
And I'm going to ask you a question that's a naive question because my area of practice is not metabolic surgery. And that is, what does a patient who is best served by a sleeve look like clinically? Who is that patient?
Well, that's a patient who is just too difficult to perform a bypass. Some patients have so enormously amount of adipose tissue centrally or a huge liver, and where you're very happy that you can just go and somehow make a sleeve, or somebody with tense adhesions, or a patient with a huge hernia, which is too complex to make a bypass, and you always can make a sleeve, or transplant patient. These are situations where a sleeve is really very helpful. Or a patient who just wants to have a sleeve because he's convinced he has a friend or a relative who has excellent results with a sleeve. So if you use this placebo effect in that patient, then it will help. But he must know he has a 34% risk of conversion up to 10 to 14 years after surgery.
I think this also, in light of that description, really contributes to us as surgeons being able to provide better shared decision-making with our patients because you do have better data to share with them.
That is definitely true.
Is there anything else that you think is important about this study that you want to highlight for our listeners?
I'm very happy we have sleeve as an alternative to other procedures such as bypass in all the variations that exist today. But if we operate on very young patients, they will have this situation for the next 60 to 70 years. And if we have a procedure like the bypass that we can reverse to normal anatomy and don't have the long-term issue of reflux in the esophagus, I know we have other side effects that can be very severe in bypass also, but still, the patient must know about these issues when he takes a decision which operation he wants to have.
I think that's a great thing to close with. Dr. Kraljević and Dr. Peterli, thank you so much for spending time with me today. I've learned a lot from you.
Thank you very much. It was a pleasure.
Thank you for the invitation.
I am Amalia Cochran, Web and Social Media Editor for JAMA Surgery, and I've been speaking with Dr. Marko Kraljević and Dr. Ralph Peterli about the long-term outcomes of sleeve gastrectomy and Roux-en-Y gastric bypass, or the SM-BOSS study. This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.